Nitric oxide is a gas that, when inhaled, dilates the blood vessels in the lungs, allowing more oxygen to be absorbed by the body. This is very helpful for people who have breathing conditions that prevent them from receiving enough oxygen, such as pulmonary hypertension. The vast majority of patients receiving nitric oxide treatment do so through mechanical ventilation in the intensive care environment. However, one limitation of delivering nitric oxide this way is that for patients who don't necessarily need to be intubated or receive mechanical ventilation, there isn't really another option for them to receive nitric oxide treatment. As such, there has been more interest in non-invasive delivery, that is to say, through interfaces that cause less discomfort to the patient. The least invasive form of delivery is a nasal cannula. Non-invasive delivery could allow for long-term treatment for patients at home, and there has been some investigation into the antiviral effects of nitric oxide at high concentrations to treat viral infections such as COVID-19. However, one problem with delivering nitric oxide through a nasal cannula is that the gas supplied mixes simultaneously with room air as it is inhaled. So then how do we know what the effective delivered dose to the patient actually is when that's a challenging thing to measure in vivo? That's where my research comes in. Using previously established methods, a realistic adult nose-throat airway replica was connected to a mechanical lung simulator which mimicked the breathing of a COPD patient. Carbon dioxide was used as a surrogate gas for nitric oxide and was delivered simultaneously with supplemental oxygen through the cannula to the replica. There are several factors that influence dose delivery. As such, we varied cannula type, gas supply flow rates for both carbon dioxide and oxygen, and the breathing patterns of the patients. While one big outcome of this research is just the measured nitric oxide concentration at the trachea, there are several other important findings. The first is that nasal cannula type had a negligible influence on the nitric oxide concentration at the trachea, while the concentration was found to be significantly different across breathing pattern. The mass flow rate at the trachea, which looks at the amount of gas flowing past the patient's trachea during the breath, was found to be far more consistent across breathing pattern. And this bodes really well for it as a possible dose metric, because if you had a characteristic range of tidal volumes and breathing rates for a given patient, the dose could be possibly prescribed by a single flow rate rather than the currently used metric of nitric oxide concentration, which has to constantly be adjusted for changes in the patient's breathing pattern. This result, combined with the nitric oxide concentrations measured during this research and the predictive equations defined, could possibly help to establish dose recommendations for nitric oxide treatment through a nasal cannula. Thank you.